Welcome, everyone. So today we're going to be talking about some complex aspects of critical care and nursing, focusing on the GI disorders and nutrition. By the end of this lecture, you guys should be able to understand and manage the common GI bleeding disorders, talk about some of those important laboratory findings, and recognize the signs and symptoms and management strategies for acute pancreatitis. We're also going to talk about the world of liver diseases, including hepatitis and cirrhosis, and also discuss the complications that can arise from liver failure. In addition, we're going to talk about some of those laboratory studies that are associated with those conditions, and as well as some nutrition things like enteral and parenteral feeding. In the end, we're going to also talk about some risks for nursing, some of the risks and also nursing interventions associated with the nutritional methods. Okay, so let's get started. First thing is that we're going to talk about is some of the bleeding disorders. Now, I know that some of you guys have already kind of gone over some of these conditions in MedSurg, so hopefully some of this is a review, but if it's not, let's just go for the ride. Okay, so GI bleeding disorders. We're going to talk about these, and they are a very significant concern in the critical care environment, okay? Especially in the ER. If somebody comes in with a GI bleed, it could be minutes. I mean, we could have days, weeks, months, or it could be something where we have minutes before that they turn critical, okay? So, or they're already critical before they get there. So, we're going to focus on 4 primary conditions: peptic ulcer disease, stress-related erosive syndrome, esophageal varices, and Mallory-Weiss tears, okay? Understanding the pathophysiology and the clinical presentation of each of these disorders is so important for you guys to be able to assess your patients in a fast manner and also intervene. So, first up, peptic ulcer. Okay, peptic ulcer disease. This is something that you probably already know a little bit about. So what it is it's characterized by ulcers that form in the lining of the stomach or the duodenum due to the corrosive action of gastric acid, and pepsin. The most common causes include infection with H. pylori and the use of NSAIDs, or non-steroidal anti-inflammatory drugs. The pathophysiology is the imbalance between aggressive factors like acid and pepsin and the defense mechanisms of the gastric mucosa. And what happens is that leads to the ulceration of that inner lining. Patients are often present to the emergency department or anywhere with epigastric pain described as burning or gnawing, which it may be relieved by foods or by taking antacid. So they'll talk about this gnawing, twisting pain, and it's epigastric region. And I always want you to remember, though, any epigastric pain, don't automatically assume it's GI because it could be cardiac, but they'll typically, like, if you hear burning or gnawing in the description of the pain, it leads us to think that it is GI related. Okay. And when we're asking them those things, like how did it start? What makes it better? What makes it worse? If they say, well, when I drink something like milk, or I take, some Tums or calcium, that makes it better. That again should lead you to it being obviously GI, but it may not be relieved, but it may. Okay. So it's not like a 100% thing. So when you're assessing these patients, you need to include a thorough history to identify those risk factors, complete the physical examination, and there are some diagnostic tests, like we can send them to endoscopy, and then we can also test for H. pylori. So endoscopy is a surgical procedure where we sit the scope down. Patient is sedated. Scope goes through the mouth and to look at the GI tract, the upper GI tract, to look for corrosive things. We also use endoscopy for other things, but obviously go into the stomach. We're looking at the surroundings and the tissues, looking for the ulcers. Okay. So when we're treating this, we're going to focus on eradicating the H. pylori if that's present with antibiotics. We're also going to work at reducing the gastric acidity with proton pump inhibitors, and also protecting the mucosa with agents like sucralfate. I can never pronounce that right. Sucralfate. It's crucial to educate your patients on avoiding NSAIDs and other irritants to promote the healing and prevent reoccurrence. And one of the things that I always ask, especially if somebody has peptic ulcers, is when you take NSAIDs, or let's just not even say that they have peptic ulcers. Let's just say you're giving patients oral NSAIDs, or you know a patient is taking NSAIDs. One of the things you can always do to promote health is make sure that they are taking it with a full glass of water and a little snack. And I always say, I want a full glass of water. I don't want a sip of water and you take those. I want a full glass, like 8 ounces. And I also want a snack, like a couple of crackers or a piece of toast minimum. When you do that, that helps the NSAIDs from like eating away at the stomach lining. And that's how I word it to a patient. But you always want to make sure that they're taking it with like food and water. If they don't have food, yes, a big glass of water is okay. But we want to make sure that they're not taking NSAIDs on an empty stomach. If a patient has peptic ulcer disease and they know that they have an ulcer, do you give an NSAID? The answer would be no. Then you're kind of stuck with Tylenol. Unfortunately, you really should avoid NSAIDs if you know that they already have an ulcer. But that's just one of those things that can happen, and it happens more frequently than people realize. Okay, so stress-related erosive syndrome. Okay, this is also known as stress ulcers. Have you ever heard of stress ulcers? Okay, well, this is the fancy term for it. So what happens with this is that, especially in the critical care setting, patients can get this due to being severe physiological stress like trauma, burns, or major surgery. The risk factors include mechanical ventilation, coagulopathy, so like they're having bleeding disorders, and or hypotension. So what happens is there's a decreased mucosal blood flow. So blood is not getting to the mucosal tissues, and hypoperfusion, which leads to ischemia of those tissues in the upper GI, lower GI tract, okay? So when you don't have blood going to tissue, ischemia, right? And then the tissue starts breaking down, okay? So then that can cause subsequent erosion of the gastric mucosa, okay? So unlike with the peptic ulcer disease, which involves discrete ulcers, the stress-related erosions are more diffuse. They're more all over the place, okay? So it's more the whole stomach, all over the place, okay? So clinically, what you're going to see is patients may present with signs of upper GI bleeding, like hematemesis, so that's blood in your emesis or bloody vomiting, okay? But often the bleeding is occult, and it's detected through a drop in hemoglobin or positive fecal occult blood. So occult means that like it bleeds and then it kind of stays in the GI system for a while. And so when blood, like fresh blood, right, is like liquidy and maybe some jelly-like or whatever, but occult blood is kind of more dried, crumbled, dark, and stools would be like tar, or like if you're vomiting up, it's going to look like coffee grounds, okay? Like dark, blackish. It's not going to be fresh red blood, okay? So assessment involves monitoring for signs of bleeding and hemodynamic instability. So endoscopy might be used to diagnose this condition. So management for stress-related erosive syndrome includes prophylaxis. So like we want to prevent it before it even happens in those patients that are at risk by using proton pump inhibitors or H2 receptor agonists to reduce gastric acidity. This is why so many of your patients get put on those PPIs in the hospital, even though they don't have a actual diagnosis of like an ulcer or something beforehand. It's we're wanting to prevent this from happening if they're at risk. Also, early enteral feedings may also help maintain the mucosal integrity. So that's another way that we can treat it. And in cases where there's significant bleeding, endoscopic interventions or surgery might be necessary. So Mallory-Weiss tears. So these are longitudinal lacerations at the gastroesophageal junction. Okay, so let me say that again. Longitudinal, so side to side, lacerations, so like tears, at the gastroesophageal, so between the stomach and the esophagus junction. These tears are usually caused by forceful vomiting, retching, or coughing, leading to a sudden rise in the intra-abdominal pressure. Patients often present with hematemesis, so bloody emesis, after episodes of vomiting. The bleeding is usually arterial and can range from mild to severe. Diagnosis is confirmed through endoscopy, which allows for the scope that's placed into the esophagus, into the stomach, to visualize that tear. Treatment is often supportive as many tears heal spontaneously. In cases of significant bleeding, though, endoscopy treatment might, like epinephrine injections into that area, which will cause that vasoconstriction and lessen the bleeding, or even thermal coagulation may be necessary. So they kind of cauterize the area with heat. Nursing interventions include monitoring for signs of continued bleeding. So if you're looking for continued bleeding, we would be monitoring. So large amounts of bleeding would affect vital signs, right? And this is applicable to any of these bleeding disorders, right? As a nurse, so if you're monitoring for signs of bleeding, vital signs, but that's only for significant bleeding, right? So obviously, if there's blood in the emesis or the stool, we want to know, but I want to know what kind of blood is it? Is it fresh red blood, or is it occult blood? Is it, if they're vomiting, does it look like coffee grounds? If they're having a stool, is it like dark and tarry? Those are things that I want to look for, okay? And where was I? Sorry. So we're going to be looking for the signs for continued bleeding. We're going to manage nausea and vomiting to prevent further tears. So we'll be giving things like Zofran, okay, to lessen the vomiting. There's other nausea medications if Zofran's not working, but that's typically one of our first lines, right? And we're also going to be providing patient education on avoiding activities that increase the intra-abdominal pressure. So like no crunches for you. Okay, so esophageal varices. These suckers can be so scary, especially if a patient comes in and they haven't been seen before and they were vomiting and nauseous and had blood for a while. These patients, I have seen it time and time again, they will code before your eyes. Doesn't necessarily mean they're going to code, but like esophageal varices can be like so this is typically, if somebody comes into the emergency department for what people call a GI bleed, this is probably the condition that they have. Not always, but if they are critical, like they're hemodynamically unstable, this is probably the cause. Not always, but like I said, probably the cause. Okay, so what is esophageal varices? They are dilated submucosal veins in the lower esophagus. Okay, like so lower in the esophagus, the veins become like enlarged. Okay, and what causes this is liver cirrhosis. So these patients are typically alcoholics or have a history of alcoholism or hepatitis or something that causes liver cirrhosis. Okay. The increased pressure in the portal venous system causes blood to be redirected to the esophageal veins. Okay. So portal, liver. So the increased pressure in the venous system around the liver causes the blood to be redirected to the esophageal veins. And they're not used to being handling that much blood volume and pressure. Okay, so then they dilate or they expand, they get bigger. They shouldn't get bigger. These varices are fragile and prone to rupture because these are like the veins around the esophagus. Like I said, they weren't intended to hold that amount of volume of blood or the higher pressure that's backing up into that area, okay? So they can break. So when they rupture, that can cause life-threatening hemorrhage. Patients might present with the hematemesis. It could be coffee ground. It could be bright red. So like if they've been slowly bleeding for a while, it could be like some coffee ground emesis or black tarry stools. And then all of a sudden the varices really rips open. And then now we have fresh blood that they're vomiting up. Okay. They also could be coming in with signs of hypovolemic shock. Okay. And that's typically when they seek healthcare in the emergency department. Diagnosis is often made via endoscopy, which can also provide the therapeutic interventions. More on that in just a second. Management includes stabilizing the patient with fluid resuscitation and blood transfusions. We will also give meds like vasopressin or octreotide, okay, because that will reduce portal pressure. Octreotide is very common to give these patients. Endoscopic procedures such as band ligation or sclerotherapy are used to control the bleeding. So in some severe cases, though, what it's TIPS is what it's called. It's called transjugular intrahepatic portal systemic shunt. You do not have to remember that, but it's a shunt. It might be considered. So nursing care involves monitoring those signs, vital signs, observing for signs of bleeding, administering meds, and preparing the patient for procedures. On the flip side, or not the flip side, in addition to that, I will tell you, so some of the most critical patients I've ever cared for in the emergency department are people coming in with esophageal varices, massive GI bleed. I will tell you this. A GI bleed is a smell like none other. It's a very acidic, bloody, sour. It's really hard to describe. Once you smell a GI bleed, you'll never forget the smell. And so when you walk into a room and you get that smell again, you will know that patient probably has a GI bleed. I remember one time we had this one guy that came in it was towards the end I was working a night shift, and it was probably like 4 a.m, and he had been vomiting for days, and he was very pale, and history of alcoholism. And by the way, we don't ever say alcoholism. We call it ETOH. So ETOH, positive for ETOH consumption. And he was very weak, like very weak. And so we took him to a critical care room. And of course, vital signs were stable, not stable. So very low end of normal, but like rapidly decreasing in their stability. So heart rate was up high because he had signs of hypovolemic shock. He was bleeding out. He wasn't vomiting when he first arrived, but he very quickly started vomiting. So those little blue vomit bags, have thousands of them on hand. He kept bleeding and bleeding and bleeding. And at one point we realized we need to intubate this patient because he's about to like lose his pulse. B, we need to protect his airway because he keeps vomiting and it's not good. So we intubated him, but he was not even, and I will tell you, there was probably at least 8 RNs working on this one patient. We pulled people from everywhere. I don't remember the last count of how many units of blood we administered. I think we like took out the whole blood bank that morning. We were all in that room, and it was like there was lines everywhere, going everywhere. We tried to get central line. We had to replace blood products. So we had flowing. He wasn't even stable enough to take him to the OR. So endoscopy came to us. They brought those big stinking machines downstairs, and we all became endoscopy nurses that day. And it was not fun because we didn't know what we were doing, but like I was having to crawl under and suction like crazy because he kept vomiting. Even when he was intubated, there was still blood coming up. It was great fun. We tried to put NG tube down there and NG tube to suction, and the amount of suction, the suction canisters kept filling up with blood. We'd get a new one in there, filling up with blood. We were like, how does this guy have any more blood left in his body? It's because we've gone through like 30 units of blood at this point. And the documentation on that was crazy. We had like 2 nurses just doing the documentation that was required for all the meds, all the units of blood. It was just intense. So these patients can be super critical and be super labor intensive, okay, to just try to maintain their heart rate. But yeah, so he wasn't even, I just never forget it. It's just one of those patients that sticks with you. But esophageal varices can be very critical very quickly. So that's why it says when you're preparing the patient for procedures, they need to go to endoscopy. They need to be able to go through with the scope and actually go and like seal off and fix the bleed, but they may not be able to. And so if you're an OR nurse, endoscopy, ER nurse, even ICU nurse, you could potentially have to have the procedure brought to you because he wasn't even stable to like leave the unit. It was fun. Okay, so some laboratory abnormalities in upper GI bleeding. Okay, so you need to know your lab values. You need to know what it means if they're high or low and what is going on in the body. Okay, so a decrease in hemoglobin and hematocrit indicates blood loss. However, remember that these values may not immediately reflect acute bleeding due to plasma volume adjustments. Also, I want you guys to remember that H&H typically starts to reflect a blood loss 4 to 6 hours after that blood is lost. So whatever your lab value comes back, that was 4 to 6 hours ago. So if they're actively bleeding and you get an H&H back, that even though like, yes, the blood specimen was taken 20 minutes ago and it's now resulted, the way that your body works, that what that result is, that's showing kind of the status of hemoglobin and hematocrit 4 to 6 hours before you even pulled that blood. So it's probably, if they're actively bleeding, it's probably even lower than that. So just remember that. So you got, yeah, that's good for that. So a BUN, why is a BUN elevated? Okay, so an elevated BUN with normal creatinine. So if the creatinine is normal, but the BUN is elevated, that suggests upper GI bleeding as blood proteins are digested and absorbed, increasing nitrogenous waste. Okay, so you would have an elevated BUN with a normal creatinine. So the other kidney function things are normal, but the BUN is elevated. That means that you probably have an upper GI bleed. So then coagulation like PT-PTT. Okay, so that might, like a prolonged PT-PTT will come up on lab results if the bleeding is due to liver dysfunction or coagulopathy. Okay, so you're also going to see signs of hypovolemia, such as electrolyte imbalances or metabolic acidosis. Serial lab monitoring is essential to assess the patient's response to the treatment and ongoing blood loss. So, as a nurse, it's really important that you monitor these lab values and don't look at them individually. You need to be looking at the trends, okay? And what is it slowly staying the same? Is it slowly decreasing? Is it slowly elevating? And what does that mean? Those are the questions you need to ask yourself, okay? Don't assume that all lab values are in real time being monitored by a advanced provider, like the physician. Like, this is the nurse's job. If you start seeing trends, you need to notify the physician. Obviously, if it's a critical lab value, you're going to notify the physician right away. But if you start seeing a trend in one way, and especially it correlates with your physical assessment of the patient, then you need to be intervening sooner than later. Okay, so now let's kind of switch gears and let's talk about pancreatitis. Okay, so we were talking about like upper GI bleeds before, but now let's switch to the pancreas. Okay, acute pancreatitis is commonly caused by gallstones and alcohol abuse. Now, this can confuse some people because people think of gallstones and they think of the liver. Okay, yes, gallstones do affect the liver, but it also affects the pancreas. Okay, gallstones can obstruct the pancreatic duct, leading to enzyme accumulation and autodigestion of the pancreas. So the enzymes aren't able to leave the pancreas. So those enzymes are breaking apart. Like, your body creates these enzymes to break apart food and molecules and stuff like that, right? To digest things. Well, if it can't leave the pancreas and it chills in the pancreas because the duct is blocked from a gallstone, then basically those enzymes start eating its own pancreas and breaking it down. That's not good. Okay, so alcohol has a direct toxic effect on the pancreatic cells and stimulates enzyme production, which then breaks down the pancreas. Okay, so hypertriglyceridemia, that's a tongue twister for me. Okay, so that's another thing that can cause acute pancreatitis, what happens is it induces it due to accumulation of fatty acids in the pancreas, which can cause the inflammation of the pancreas. Certain medications and abdominal trauma, including procedures like ERCP, can also precipitate pancreatitis. So it's important as a nurse to identify those underlying causes so that we can make sure that we're treating the cause so that we can prevent future episodes as well. So in acute pancreatitis, the premature activation of the pancreatic enzymes within the pancreas causes the autodigestion. Okay, so autodigestion, it's eating itself, inflaming. So that leads to inflammation and tissue damage of the pancreas. This results in severe abdominal pain. These people, it is so hard to relieve their pain. No 4 of morphine is going to touch these patients. We're talking Dilaudid, we're talking fentanyl, we're talking some strong suckers, and even that might not even help them. It's very, very sharp pain, okay? The pain so it's typically in the epigastric region, so kind of in the middle, radiating to the back, and often on the left side towards the back. Okay, so it's upper epigastric to the left, on the left side of the patient, obviously, where the pancreas is. So the pain often worsens after meals due to that increased enzyme secretion. So as you're eating food, your body says, hey, we got to break down this food. So it creates more enzymes. Okay, so after you eat, all of a sudden the pain comes and it's horrible. These patients also are very nauseated, and they could also vomit, and that's very common with pancreatitis, and that will lead to fluid loss and electrolyte imbalances as well. So the inflammatory process can extend beyond the pancreas. So it's not just the pancreas that's inflamed, and it can cause systemic effects like tachycardia, hypotension due to third spacing of fluids, and respiratory distress if the diaphragm becomes irritated. Okay. So you need to be able to assess the patient fully, and then recognize if these signs are present, because we also need to have prompt treatment. Said that backwards. Sorry. Okay. Lab tests for acute pancreatitis are going to help us confirm the diagnosis and also assess how severe it is. Elevated serum amylase, LACE. When you see LACE, ACE, those enzymes, right? So elevated serum amylase and lipase are hallmark findings, with lipase being more specific to pancreatitis. Hypocalcemia can occur due to fat saponification. What that is it's where fatty acids combined with calcium, which would lower the serum calcium levels. So that can lead to neuromuscular irritability, because if the fatty acids are combining with the calcium, then there's not enough free calcium roaming in the blood. So then if there's not a lot of free calcium roaming in the blood, it's going to affect those calcium channels, and especially the cardiac muscles. Okay. So, and not just cardiac muscles, but all muscles, right? Because we need calcium for your muscles to work. Okay. So neuromuscular irritability might work. And so there's Schwastick's and Trousseau's sign. If you don't know what those are, you need to know what those are. Go back to your health assessment days. Schwastick's is it on the screen? No. Okay. Schwastick's is spelled Chvostek, and Trousseau's is Troussseau. Look up both of those signs. So if you see it, it's a thing with a hand, that's Trousseau's. You know that there's a calcium issue in electrolyte issue. Okay. So elevated liver enzymes may indicate gallstone involvement, which would be obstructing that bile flow. Leukocytosis signifies the inflammatory response, and hyperglycemia may result from impaired insulin secretion due to the damage of the pancreas itself. So not good. So you might have to be treating a whole bunch of things. Okay, so managing acute pancreatitis involves several key steps. Okay, so the number one it's going to be like right up in your face is pain control, often requiring IV opioids, like I said, for severe pain. We're going to keep the patient NPO, because that's going to help rest the pancreas by minimizing the stimulation and of the enzymes and the secretion of them. We're going to try to have gastric decompression with an NG tube that can alleviate the vomiting and abdominal distension that can occur. We're also going to be doing fluid resuscitation with isotonic IV fluids, addressing that hypovolemia from the third spacing and vomiting. We're going to be doing electrolyte replacement, particularly calcium and magnesium, if it's necessary. Nutritional support should transition from enteral feeding as soon as tolerated to maintain gut integrity. Okay. Identifying and addressing the underlying cause, such as removing the gallstones if that's the cause of it, or providing resources for alcohol cessation, is also super important to prevent it from reoccurrence. Now, what is the priority here? It depends on the assessment of the patient. Obviously, if we have third spacing and there's hypovolemia, we need to worry about circulation, right, before other things. Pain is not a priority if you have something wrong with airway, breathing, or circulation. Pain is a psychosocial need. It is not a physical need. So remember that, okay? So now let's talk about liver diseases. Okay, so we switched from the pancreas. Now we're going to go on the right side, and we're going to talk about the liver. Okay, liver diseases can be caused by many different things. One of the most common ones that people think about is hepatitis. So there's viral hepatitis, particularly B and C. Those can lead to chronic infection and liver damage. Hepatitis D requires a co-infection with B for it to actually progress in its disease state. There's also hepatitis A, but we're not going to cover that right now. You should have already covered that. And if you haven't, go back and read up on hepatitis A. So and let me add to that. You should have already covered Hep A in MedSurg. If you haven't, just go refresh your memory on Hep A. So alcoholic liver disease results from prolonged excessive alcohol intake, leading to inflammation and fibrosis of the liver. Okay, non-alcoholic fatty liver disease, or NAFLD, is becoming more and more common in our society right now, okay, because of the rising obesity rates, especially in America, where and what's happening is there's fat accumulation on the liver, and that's causing inflammation, and it can lead to potential cirrhosis. I don't know, there's been like a push lately about talking about fatty liver disease, and like most people think, oh, there's this little extra fat on my liver, not a big deal. Big deal. Big deal. We don't want it. And you can reverse it. But it involves lots. You can reverse it if you catch it early. Let's put it that way. And we want to encourage our patients to reverse it if they have a fatty liver. Okay. Autoimmune hepatitis. Yes. Okay. Autoimmune hepatitis involves immune-mediated destruction of liver cells. Okay. Drug-induced liver injury can also occur from medications like acetaminophen, Tylenol, when taken in overdose or from certain herbal supplements. There's other things that are metabolized by the liver, but I'm telling you right now, Tylenol is so hard on the liver. Tylenol with alcohol, oh my gosh, so hard on the liver. As a nurse, you need to be able to recognize that these causes so that you can promote better health. You can encourage to be healthier about things. I cringe because I think about, there was I once had a patient that she was telling me her story. And it was really sad. So she was in end stage, like liver disease, cirrhosis, really, really sick, jaundiced, yellow as anything. Okay. Everything was yellow on her. And she was so young. And I had asked the question about like a liver transplant, like was she on the list? What was going on? And she said that she had been denied access to the list because it was a self-induced cirrhosis. In her teens, she would go drinking, okay? And she also popped Vicodin all the time, which has Tylenol in it, hydrocodone and Tylenol. And she was excessive in both, and it just shot her liver. And her providers had told her that she's not a candidate. It was so far gone. Like she knew that she was already on hospice care, but like, it was just so sad to me. She was in her early 20s. She was basically like the age of most of you nursing students. She was like 21, 22, 23 at the time. And she just had many, many years. And I mean, not that it wasn't like it was 30 years by any means. She wasn't even 30 years old, but she had just drank heavily in her teens. And she was popping Vicodin left and right. And it was so sad. And I will always remember, there's certain patients I just remember her because I remember thinking like, oh, she just needs another chance. But like, she didn't get it because it was self-induced. Super sad. Okay. So let's compare and contrast hepatitis B, C, and D. Okay. So I pause the screen, read a little bit more about this so you can compare. This is a really good thing to know the differences between if you don't already know. I'm going to go over the highlights. Okay. So they differ in their transmission, if their chronicity, so like how they can turn into possible chronic conditions, because they don't always turn into chronic conditions, and also the management. So hepatitis B is transmitted through blood and body fluids. There is a vaccine available for the prevention of it. Okay. So, and it starts at the hospital when the baby is born. We start giving Hep B vax early on. So a small percentage of the patients that get this become chronic carriers, and it could progress into cirrhosis and liver cancer. So hepatitis C is primarily blood-borne. People typically get this through IV drug use, but like a dirty needle from a tattoo, dirty needles, just think dirty needles typically. And that has a high rate of chronic infection leading to liver transplantation. It can be cured, but it's not a guarantee. So there is no vaccine for Hep C, but effective treatments can cure it, like I said. So hepatitis D, that requires you to already have Hep B in your system for replication and for it to lead to a more severe disease. So preventing hepatitis D hinges on vaccination against Hep B, if that makes sense, okay? Because you need the Hep B to make Hep D bad. Okay, so if you can prevent Hep B, then Hep D won't hurt you per se. It won't turn into a chronic condition, okay? Okay, so cirrhosis. This is, okay, when we say that somebody has cirrhosis, this represents that final stage of chronic liver disease where normal liver tissue is replaced with scar tissue. So cirrhosis of the liver is just basically a very super scarred liver that's not going to function properly. Chronic alcohol directly damages liver cells, leading to fibrosis. Chronic viral hepatitis causes ongoing inflammation and cell death, promoting scarring. The NAFLD, fat deposits lead to inflammation, and then fibrosis, similar to alcoholic liver disease. So that fatty liver disease is, and when I say fibrosis, scarring, okay, damage, okay. So the fibrotic tissue and regenerative nodules of the liver disrupt the blood flow of the liver tissue, which increases resistance, and it results in portal hypertension. Remember when I said portal hypertension? That can lead to an increased pressure in the portal vein, which then could lead to ascites, big belly, esophageal varices, we've already gone over that, and splenomegaly, which means enlarged spleen. So when we mess with the portal vein of the liver, there's normally like really high blood pressure in that area. But if we are messing with it where it can't flow freely like God intended, the blood backs up into those things, and it can cause those esophageal varices, an enlarged spleen, or ascites of the abdomen. Okay, so just remember that. So complications of liver failure. Okay, so liver failure leads to severe life-threatening complications. We've already kind of talked about a few of these. Hepatic, anytime you see hepatic, think liver. Hepatic encephalopathy. Encephalopathy, brain, okay? So liver, brain, okay? And hepatic encephalopathy results from the accumulation of toxins like ammonia, which in the blood system, which causes neurological impairment, okay? So when your liver isn't functioning properly, ammonia builds up in your blood system, and that will cause damage to your brain, okay? And like the screen says, you could go from confusion to coma, okay? Then hepatorenal syndrome is a functional renal failure due to changes in the blood flow and vasoconstriction that affects the kidneys, and that can be caused by liver failure. Also, spontaneous bacterial peritonitis occurs when bacteria translocates from the gut into the acidic fluid, not acidic, but ascitic. Like, so ascites, think abdominal fluid. Let's just go with that. Abdominal fluid, leading to the infection. These complications arise due to the liver's inability to detoxify substance, producing proteins, and maintaining the fluid balance. So early recognition and management are critical to improve outcomes. Just think about what your liver does. Your liver is like your filter for your body, right? Yes, your kidneys are too, but your liver breaks down things. It helps like detoxify your whole system. So if it's not working, everything else is going to build up, and you can't filter things. It can't. Your liver also deals with your coagulation. You're going to have coagulation issues. There's so many issues of liver failure, and it's super painful. Okay, managing liver failure involves comprehensive approach. We're going to look at multiple things. We're going to do supportive care to address any fluid balance issues, any electrolyte disturbances, and also nutritional needs. Lactulose is a key medication for hepatic encephalopathy, because what lactulose does is it reduces ammonia absorption. We're also going to give these patients diuretics to manage the ascites, but be careful monitoring be careful to monitor. You need to monitor because it's necessary to prevent renal impairment. Also, when they have ascites, you're going to be possibly doing peritoneal taps to pull fluid off their abdomen, because that could be putting pressure on all sorts of intra-abdominal pressure. It could also be putting pressure on their diaphragm, which makes it harder for them to breathe. There's lots of stuff that could be going on, and we want to worry about, because when you pull off fluid from the abdomen, you might have fluid shifts. So we're going to be monitoring albumin. There's lots of stuff that's going on. Okay. And then let's talk about, so antibiotics for infection. If we think that they have bacterial peritonitis, we'll be giving them antibiotics as well. And we'll also be possibly prepping them, testing them to see if they're candidates for liver transplant. And if they are, we will be addressing those needs. We've already talked about organ donation. And like I said, that girl that I had taken care of, she was already on hospice at that time. So if they're not eligible for a liver transplant, we're going to be just doing palliative care. So lab studies. Okay. Elevated serum bilirubin levels lead to jaundice. Okay. So when they have elevated bili, you probably remember that from PD, right? Or OB, whenever you learned about babies. Jaundice, and it can help differentiate between hepatocellular and obstructive causes. Okay. So if their bilirubin is elevated. Okay, so let me start again. Bilirubin tests help differentiate between the hepatocellular and obstructive liver failure by analyzing the types of bilirubin elevated in the blood. In the hepatocellular failure of liver damage, damaged liver cells cannot effectively conjugate bilirubin, leading to elevated levels of indirect bilirubin. In obstructive failure, so like the bile duct blockages, that is where liver failure, like the gallstones and all that kind of stuff. So when they're blocked, they prevent the excretion of conjugated bilirubin, causing elevated levels of direct bilirubin in the bloodstream. So elevated and indirect means that there's something going on at the cellular level that caused the liver damage, versus if there's elevated and direct bilirubin, that means that there was like a blockage. So we probably can reverse that one much faster, easier than the indirect bilirubin due to hepatocellular failure, if that makes sense. I hope that makes sense. Okay, anyways. Okay, moving on. So low albumin levels results from decreased synthesis, affecting oncotic pressure and leading to a fluid accumulation. So albumin is one of those, especially if they have ascites, their third spacing or anything like that, we're going to be testing and looking at albumin levels. Okay, so we might need to give them albumin so that we can bring more blood flow back into the vasculature system, and they're not third spacing. If their albumin's low, there's probably swelling in places, like their third spacing, most likely. Okay. Let's go back. Prolonged PT and PTT indicate impaired synthesis of clotting factors, increasing bleeding risk. Okay. Elevated alkaline phosphatase suggests cholestasis or biliary obstruction. We're going to hop on that for a section. Cholestasis is think chole, C-H-O-L-E, chole. That should always think liver, like cholecystitis is what we call like gallbladder issues, right? Cholestasis is a biliary obstruction. The other place that you may have heard about this, or you may not have heard about this, is in OB. Cholestasis, long story short, the placenta can basically make your liver wacky, and you can develop cholestasis. Cholestasis, you will start having build up in your system of those bile salts, because it's a biliary obstruction. So those bile salts actually build up in your blood system, and it causes super itching of like hands and feet, sometimes skin. Sometimes this is associated with that other liver thing. I'm not an OB person, but the liver thing, y'all probably know what I'm talking about. That's dangerous. But cholestasis, it typically, like the bile salts like fill up in your hand. I'm getting itchy just thinking about it, in your hands and your feet. And so they have to treat that. So just remember that. I don't know if you learned that, but that's a cool little like thing. Okay, so now let's talk about ammonia. So high ammonia levels are associated with hepatic encephalopathy. So if you have a high ammonia in your system, your brain is probably not going to be functioning great. So necessitating monitoring of the mental status. So we're going to start doing neurochecks on these patients. So we're going to be doing regular lab draws on these patients so that we can help evaluate how the disease has progressed, and also like how sick they are. But we also need to be able to know these so that we can do treatments, symptomatic treatments for the different things. Okay, so now while we're kind of on this, we have to talk about addiction. And I know that you get some of this in behavioral health, so we're not going to get into crazy details on this, but addressing addiction in patients requires us to first reflect on our own beliefs and biases. This is so important with anything that you could ever have a judgment on. You have to first know how you feel about something before you could ever help somebody with their issue, okay? Like if you have a prejudice towards them, you might have grown up in an alcoholic household. You might have grown up with abuse. Who knows? You might have been neglected, or you might have never been exposed to it, so you don't really know much about it. So you need to first always self-assess how you feel. And there's no right or wrong reason. You're not wrong if you feel a certain way about a certain condition like this. Okay. Um, you just have to be able to understand it so that you can provide the best care possible to our patients. Okay. So you need to recognize, um, addiction isn't always by choice, right? Like yes, people do make a choice to like take a medication, but then very quickly your body reacts to it. And so a lot of it is not a choice after that addiction like sets in. If that makes sense. Okay. So recognizing addiction as a chronic disease that alters that brain chemistry will help you as a nurse provide more compassionate care for your patients. So it's important to approach your patients in a non-judgmental way. If you're judgy about a condition, like check it at the door is what I'm going to say. Okay. If you are really judgy about it and it's really hard for you to separate yourself, then ask to switch patients with a patient. Like you want to always provide the best care possible. And if you just can't do it in that moment, then ask to switch with one of your colleagues. Okay. Talk to your charge nurse about it. But just recognize that our attitudes can significantly impact patient outcomes. Okay. Positive support can enhance compliance and treatments and improve recovery rates. As a professional, which you guys are professionals, we have an ethical obligation to treat all patients with dignity and provide the highest standards of care. So denial is a big barrier in treating patients with alcoholism. Patients may downplay their drinking. I will tell you, so often when a patient comes into the ER and they've been drinking and you ask them how many drinks have they been drinking tonight? And cops will say the same thing. For some reason, everybody's always like, I've only had 2 drinks. It's always 2. You're like, not really, because you're not coming off like you just had 2 drinks. But anyways, patients often downplay their drinking. They and attribute it to external factors, or they're going to rationalize their behavior. Like, I just had a bad day. I only do it one time. Hey, I was just socially drinking. I just socially drink every single day of the week, and I socially drink for 6 hours of the day. You're like, okay, thank you for being honest with me. So just remember that, okay? So when a patient is in denial, this is going to hinder their ability to seek help and engage in their treatment. Okay. So as a nurse, we can employ strategies like motivational interviewing to gently challenge denial and promote self-awareness. This involves active listening. So we're going to listen to understand. We're not going to listen to respond. I'm going to say that again. You're going to listen to understand. You're not going to listen to respond. I'm not saying you're not going to respond. I'm going to say that the goal of you listening so that you truly understand what the patient's saying, not so that you can quickly respond to whatever they're saying. Okay. You want to express empathy, and also you want to help patients explore the discrepancies between their goals in life, their goals in health, their goals in whatever, and how their behaviors might affect those goals. Okay. Supporting patients through these stages of changes is going to enhance their readiness to possibly adopt healthy behaviors and improve the likelihood of successful recovery. But ultimately, if a patient's not ready to accept or realize what's going on, they're not ready. And you can't make somebody do anything. They have to be ready for it. So we can assist that by trying to be motivational, but we're realistic with them, but we're not judgy, okay? So the vulnerability model of recovery emphasizes that addiction is multifaceted. It involves biological, psychosocial, and social components. Biological factors like genetics and neurochemistry can predispose an individual to different addictions, okay? We all know that. Psychological aspects such as stress and trauma and coexisting other mental health conditions can also play a significant role. Social factors like peer influences, environmental stresses can also contribute to the issue. So as nurses, we need to be providing holistic care. And what that means is addressing all of these areas, not just the physical dependence. By helping patients develop coping skills, enhancing their social support networks, and also addressing those mental health needs, hopefully we can help improve their resilience and support the sustained recovery from alcoholism. So let's talk about nutrition now. Okay, so again, this should be a review. So in critical care, ensuring adequate nutrition is vital. NG tubes are suitable for short-term feedings in patients who cannot swallow but have a functional GI tract. PEG tubes are used for long-term feeding needs, and those are inserted directly into the stomach through the abdominal wall. And PEG-J tubes deliver nutrients directly into the jejunum, reducing aspiration risk in patients with gastric motility issues or those high aspiration risk patients. Indications include conditions like stroke, head injury, or severe malnutrition. So you need to be verifying tube placement. That is essential to prevent those complications like aspiration. And to verify that tube placement, you need to use methods like x-rays initially, and also regular checks of tube length and aspirate characteristics like the pH level. Again, should be reviewed. Enteral nutrition, while beneficial, comes with also some potential complications. So aspiration pneumonia is a serious risk, particularly in patients with impaired cough or gag reflexes. Ensuring proper tube placement and patient positioning can mitigate these risks. Tube displacement or obstruction can interrupt feedings and require prompt attention to maintain nutritional support. Infection at the insertion site also could be an issue, and that necessitates strict aseptic technique and regular monitoring of the area. GI symptoms like diarrhea may also result from a rapid feeding rate. So we don't want to feed them too fast, or from formula intolerance. So they may have like an allergy to what we're giving them. While constipation can also occur due to the low fiber content. Metabolic complications, including hyperglycemia and electrolyte imbalances, require regular monitoring and adjustments of the feeding regimen. Okay, nursing interventions are crucial for safe, effective enteral nutrition. One thing that we need to do is elevate the head of the bed. That reduces the risk of aspiration by preventing reflux of the feeding contents, okay? We need to be regularly checking tube placement and the patency so that we can ensure that the feedings are delivered correctly and reduce those complications. We're also going to be monitoring gastric residual volumes, helping us to assess how well the patient is tolerating the feedings, if they're able to actually digest or if they're staying in the stomach for a long time. Remember that high residuals may require adjusting the rate or the type of the formula. We also are going to be providing meticulous skincare around the tube site, and that's going to prevent infection and skin breakdown, and educating our patients and their families about all these things and helping to empower them to participate in their own care and also recognize those signs and symptoms of complications. Okay. Administering meds via enteral feeding tubes requires careful consideration to prevent interactions and complications. Certain medications can interact with the enteral formula, and that will affect the drug absorption and or the tube patency. So often we're going to crush those medications, but that can also have issues. So crushing medications can increase the risk of tube occlusion. Using liquid formulations when possible is the preference, okay? So it's important to flush the tube with water before and after administering each medication to prevent clogging interactions, okay? You're supposed to be doing meds individually. Have you seen nurses crush a whole bunch, put them all together? Yes, that's not best practices, but they do it. Monitoring the patient for therapeutic outcomes and any adverse effects is also important, just like you're giving a PO medication, okay? So you want to collaborate with the pharmacists before you give meds, especially if you never give them. Make sure it's okay to crush or whatever. What's the best way? Is there an alternative, a liquid form? So be checking with pharmacy about the best way for meds when a patient gets enteral feedings. Now, parenteral nutrition, like TPN. TPN is administered. This is an alternative to when you can't do enteral feeding. Okay, so then we're going to do parenteral. TPN administered via central veins due to its high osmolarity. Okay, so it needs to be in the central line. So, and because the TPN can irritate peripheral veins. PPN is less concentrated and suitable for short-term use through peripheral veins. Vascular access devices like PICC lines or central venous catheters are used for safe administration very often. The composition of TPN includes high concentrations of dextrose, amino acids, vitamins, and minerals to meet the patient's nutritional needs, okay? Lipids supply essential fatty acids and additional calories. Close monitoring is essential to manage potential complications like hyperglycemia, electrolyte imbalances, and catheter-related infections. So now let's talk about refeeding syndrome real quick. Refeeding syndrome is a serious and potential fatal condition that can occur when nutrition is reintroduced to severely malnourished patients. These patients haven't been eating for a while, and we do not, like if a patient has been starved, especially if they've been neglected. This happens more often in a pediatric population, but it can happen in anybody. Somebody that was like lost in the wilderness for like days on end and they haven't eaten for forever, or somebody that was just severely abused and neglected for a long term, okay? So the sudden increase in glucose what happens, okay, is the sudden increase in glucose intake stimulates insulin production. That's going to cause electrolytes like phosphorus, potassium, and magnesium to shift into the cells, okay? So this is going to lead to dangerously low serum levels, which can cause cardiac arrhythmias, muscle weakness, and neurological symptoms. Patients at high risk include those with anorexia nervosa, chronic alcoholism, and prolonged starvation. Preventing refeeding syndrome involves starting nutrition at a low caloric level first. And then we're going to gradually increase the intake and closely monitor and correct any electrolyte imbalances that pop up. So this is often an interdisciplinary approach. We're going to get nutrition on board, obviously, to help us with all this kind of stuff. And we're going to be monitoring and doing lab values very frequently. So that is some of the summary and key takeaways. I'll let you pause and read as a little refresher, but that is it for Module 10. Don't forget to do the readings for this module and review the learning objectives. And I will see you guys in class.